I know.
Okay, couple of things. So we had one more person call in sick today and request a Zoom, so I'm doing another Zoom broadcast. So once again, may as well record it. So the recording will be there for the future. Let's talk very briefly about the lab exam. The average was 49.5 out of 59, so 84.3%. So the average continues to go up. So that's a good thing. Good job. There weren't any that seemed to be particularly troubling or problematic. I mean, obviously, different people miss different questions, but there didn't seem to be any that were consistently problematic for everybody. But I did notice a couple of common spelling errors pop up. There was nothing on this exam where the answer should have been ophthalmic, but I did have a number of people answer ophthalmic for a couple of different things. And most of the people who answered ophthalmic spelled it wrong. It's O-P-H. T-H. There's that extra pesky little H in there. And then there actually was something in here called sagittal suture on the calvarium of the skull. And people continue to misspell that with 2 G's and 1 T. It's not, it's 1 G, 2 T's. Okay, so that is one you're likely to continue to use throughout your career. So make sure you learn how to spell it. And actually, kudos on one. There are always a few questions that I think should be really easy that everybody should get, and then some kind of moderate ones that some students will get and some won't. And then there's always the hard ones that I wonder about. And so question 22 was one of the brains, and I tagged 2 of the arteries. 22A was the posterior communicating artery, and 22B was the posterior inferior cerebellar artery. And I was really pleasantly surprised that most people got both of those, because they were tricky, especially the posterior communicating. It's just a hard tag to see. It was a very delicate little artery, but a lot of people got that one right. So good job. All right, I'll have the key in lab as I usually do, if you want to look at anything. So today in lab, we're going to do 2 different dissections. The first one is going to be largely looking at things that we've already seen, just looking at them in a slightly different area. It's a dissection known as the root of the neck. I want you to do that dissection as quickly as you can. Try to power through that first one, because the second dissection that we're going to do, the temporal fossa and infratemporal fossa, is a little bit more involved and actually involves use of bone saw, because we have to cut off the zygomatic arch, cut off part of the mandible. So try to get through the first part relatively quickly. As I said, we've already seen some of the structures in the root of the neck. We're actually going to come back and see some of the structures in the root of the neck again on Thursday, because Thursday is when we disarticulate the skull from the vertebral column and flop the head forward. And that's actually going to allow you to see things like the scalene muscles and the brachial plexus and subclavian artery and so forth even more clearly. So we'll get to see some of this stuff actually a little better on Thursday. So you can go through this part of the dissection fairly quickly. But basically the root of the neck is just the area at the base of the neck where the neck attaches to the thorax. And there are a lot of structures in this area that are passing vertically between the neck and the thorax. So things in the neck that are passing down into the thorax, like the vagus nerve, the phrenic nerve, the internal jugular vein, heading back towards the heart. Things that are coming up out of the thorax, heading up into the neck and into the head, like the common carotid artery. Some muscles in this area. But there are also structures in the root of the neck that are passing from the neck into the upper limb. They're actually passing from the neck down into the axilla and just happen to be passing through this area. So that would include things like the subclavian artery and vein coming up out of the thorax, passing through the root of the neck on their way into the axilla, as well as the trunks of the brachial plexus coming from some of the cervical spinal nerves and then heading out into the axilla as well. So I don't know that we'll actually be able to see the esophagus because it's always hidden behind the trachea. We'll see the esophagus later on Thursday. We definitely will see the trachea as well as the cartilages that make up the larynx, vagus nerve and phrenic nerve and things, like I say, heading down into the thorax, common carotid, jugular vein. We will look briefly at the scalene muscles, although we'll see those better on Thursday after we get all of the anterior neck stuff out of the way. You are going to do a dissection of the thyroid gland today. So that'll be one kind of new, unique thing that you haven't really focused on before. And we're going to try to find a couple of lymphatic ducts. Most of the areas that we've been dissecting already, with the exception of some of the stuff inside the head, there aren't any lymphatics around the brain, but all of the other areas that we've been dissecting have lymphatics, little tiny lymphatic vessels, but you haven't seen them because they're so small. Some of you may have seen an occasional lymph node, but you haven't seen any actual lymphatic vessels. Today, we're going to go looking for the two largest lymphatic vessels in the body, but even though they're the largest ones, they're still actually quite small and kind of hard to find, but we'll go look for them. So this is the root of the neck. This is the area where we're going to be dissecting. If you look at the right-hand side of the slide, you'll see the trachea. It's a little hard to tell, but up at the very top of the trachea, up above that thyroid gland, is where you'd find things like the thyroid cartilage and cricoid cartilage, so the structures that form the larynx. And then you see some of the tracheal rings down below, heading down into the thorax. You've got the thyroid gland sitting right there that sits on the anterior surface of the trachea. Just lateral to the trachea and the thyroid gland, we have some of the structures found in the carotid sheath. So the internal jugular vein, the common carotid artery, and vagus nerve, these are all things that would be found within the carotid sheath. Then some things that we haven't really seen before, or at least we haven't seen them in this area. There's no label on this artery down here, but the artery that I'm kind of hovering the cursor over right now, going back and forth, this is the brachiocephalic artery. Remember, that's present only on the right side of the body. And this is the point where it then splits to become common carotid going up into the head, and then right subclavian artery that's eventually going to pass over into the axilla and become the axillary artery right over here where it crosses the first rib. And then you also see the subclavian vein running with it. Even farther laterally, we get into the scalene muscles, which you will be able to see today, but like I said, you'll see them actually a little clearer on Thursday once we get some of this other stuff out of the way, when we reflect the head forward. There are 3 scalene muscles in total. Only 2 of them are identified on this slide. This is the anterior scalene muscle here, which is originating on the transverse processes of the cervical vertebrae and has its insertion on the first rib. You can't really quite see the insertion of it on that first rib, but it'd be right in this area here. The middle scalene lies more posteriorly, and that has the exact same attachments. It's originating up on the transverse processes of the cervical vertebrae, higher up in the neck, and it's also inserting here on the first rib, just a little bit more posteriorly. And passing between the anterior middle scalene muscles, we have the upper parts of the brachial plexus. So if you look really closely at the slide, you'll see there are 2 independent branches that are just barely visible up here, kind of behind that artery that's identified. These would be the ventral rami of C5 and C6. So you're actually seeing all the way up to the level of the ventral rami. And then right where the label is pointing for brachial plexus, that's actually the superior trunk, where the ventral rami of C5 and C6 are joining together. And then notice that that superior trunk is relatively short and it splits again. That's where it's splitting into its divisions. So we have an anterior division and posterior division of the superior trunk. And then just a little bit below the superior trunk would be the middle trunk, which is formed entirely by just the ventral ramus of C7 by itself. And then you can't quite see inferior trunk here, but you'll be able to see all of these trunks of the brachial plexus passing out between the two scalene muscles. Another nerve that I've mentioned before, and a few of you actually did see it in the body, is the phrenic nerve, running vertically across the front of the anterior scalene muscle. So that's originating from spinal nerves C3, C4, and C5. And then it crosses the anterior scalene muscle like this, running vertically across the front of the muscle, and then passes down into the thorax, where it's eventually going to innervate the muscles of the diaphragm. Also shown on here are some small arteries, one of which we've actually seen before, although you might not remember it. We're going to try to look for something called the thyrocervical trunk, which is a branch off of the subclavian artery. It may be fairly well hidden behind the internal jugular vein and some other things, so you may have to look behind some of the structures in the carotid sheath to look for it. It may also be partially hidden behind the anterior scalene muscle, so it might be hard to see the thyrocervical trunk, but be aware that it splits into three branches. One branch is called the inferior thyroid artery, which brings blood up to the thyroid gland. So the thyroid gland actually gets blood from four major arteries. There are two superior thyroid arteries that we've already seen. Those are branches off of the external carotid, and one of them was actually on the test yesterday. There are also two inferior thyroid arteries coming up from below from these thyrocervical trunks on the left and on the right. Two other branches off of that thyrocervical trunk include a transverse cervical artery, which is going to cross the scalene muscles, cross the brachial plexus, and head towards the back. You may have actually seen this way back on the very first dissection, but not actually recognized what it was. If you remember seeing an artery on the deep surface of the trapezius, that was this transverse cervical artery. It actually ends up on the deep surface of the trapezius. The other artery that's crossing from front to back here is the suprascapular artery, and that's one you definitely have seen before, because that's the artery that goes over that little ligament, over that notch on the superior border of the scapula. We saw that when we did the posterior shoulder dissection. This is where it's coming from before it heads back to the back of the scapula. You will be looking at the thyroid gland today, or at least trying to. You have to move a lot of the strap muscles out of the way. So you have to reflect sternohyoid and sternothyroid back out of the way in order to get a good look at the thyroid gland. I can't remember if the dissector actually tells you to remove it or to cut it in half and remove part of it. It's not a big deal if you cut it and remove either the whole thing or part of it. Just do whatever the dissector tells you to do. The thyroid gland has a pretty distinctive structure. Notice that it has two large lobes. There's a right lobe, obviously on the right side of the body, sits just to the right of the trachea. There's a large left lobe sitting just to the left of the trachea. Those two lobes are then joined in the middle by a narrower bridge called the isthmus. Another commonly misspelled word, it's even hard to pronounce. It's the isthmus, I-S-T-H-M-U-S, isthmus. If any of you are fans of geography, you may be familiar with this term. Anytime you have a narrow bridge of land connecting two different large land masses, it's known as an isthmus, most famous being the Isthmus of Panama that connects Central America to South America. There are other isthmuses elsewhere in the world, but that's a pretty well-known one. So it just refers to a narrow connection, in this case, connecting the left and right lobes of the thyroid gland. Now, in addition to the left and right lobes and the isthmus, there's an additional lobe that's typically present in about 50% of the population and absent in about 50% of the population. So you've got a 50-50 chance of having this additional lobe on your cadaver. It's called the pyramidal lobe, and it's typically a very skinny lobe that extends superiorly from the isthmus, heading up towards the neck, heading higher up in the neck. It's actually a remnant of the way the thyroid gland develops. It's kind of an interesting story about how the thyroid gland develops in the embryo. The thyroid gland actually develops as an outpouching from your digestive tract, right near the back of the tongue. And even in the adult, you could look at the very back of the tongue, right in front of the epiglottis, and find a little indentation in the back of the tongue known as the foramen cecum, which was the original origin of the thyroid gland. So you have this outpouching of the oral cavity or the digestive tract at the back of the tongue that forms a tube that then grows down from the back of the tongue down into the neck. That tube eventually splits into a left branch and a right branch, and the tube just splits over and over and over again, eventually giving rise to all of the individual cells that make up the thyroid gland. In fact, that's how most glands develop, is just a branching of a tubular structure. So that tube that extends from the foramen cecum in the back of the tongue all the way down to the thyroid gland that actually gives rise to the gland is called the thyroglossal duct. Thyro, meaning thyroid gland, glossal, referring to tongue. So there's this thyroglossal duct that grows down from the back of the tongue and eventually becomes the gland. In the adult, that thyroglossal duct eventually kind of disappears, but oftentimes additional glandular tissue will form along the length of that duct. And so that's where this pyramidal lobe comes from. It's additional thyroid gland tissue that forms along the course of that remnant of that thyroglossal duct. And sometimes this pyramidal lobe can extend all the way up to the chin. All right, something else that's shown on this slide are two lymphatic ducts that we're going to try to find, although admittedly they're small, they're delicate, and they're quite difficult to find. If you look at the point where the internal jugular vein and the subclavian vein join, and I realize that the veins are not actually identified on here, but the two large veins running vertically are your internal jugular veins, running with the carotid arteries in the carotid sheath. And then the more horizontal vein that's coming from the axilla, coming up from the upper limb, that's the subclavian vein. And notice that there's a point here where the left internal jugular and left subclavian vein join. And then same thing over on the right, the right subclavian or right internal jugular and right subclavian join. And it's right at that point where those veins join that these lymphatic ducts are draining back into the venous system. I'll explain more about lymphatics in just a minute, where exactly is this fluid coming from? What does it do? Why does this fluid flow back into veins? So all of the fluid in these lymphatic vessels is actually flowing back into the venous bloodstream through these two ducts. The ducts appear to be roughly symmetrical. So the one on the right side of the body is called the right lymphatic duct. You might think that the one on the left would just be called the left lymphatic duct, but turns out these are not actually mirror images of one another. The two ducts are not perfectly symmetrical. They're actually responsible for draining lymphatic fluid from rather different areas of the body, shown on this slide here. So in the upper part of the body, the two lymphatic ducts are draining essentially symmetrical areas. So the right lymphatic duct drains the right half of the head, the right half of the neck, the right half of the thorax, and the right upper limb. The thoracic duct, which is found on the left side of the body, drains the left half of the head, the left half of the neck, the left half of the thorax, and then the left upper limb. So basically from the waist up, these two ducts are draining symmetrical areas of the body, left and right halves. But the thoracic duct, the one that's draining into the left side, also drains everything. Excuse me, I misspoke before. I said from the waist up. I really mean from like the ribs up, from the chest up. The thoracic duct is also draining the entire abdomen and both lower limbs. So the thoracic duct, which is draining into the left side, is actually draining a much larger area of the body. And thoracic duct is slightly larger in diameter because it is draining lymphatic fluid from a larger area of the body. Although even being larger, it's still surprisingly small, considering that it's retrieving lymphatic fluid from such a large portion of the body. So when I say that a lymphatic vessel is draining part of the body, here's what I mean by that. So you have arteries, of course, that bring blood into capillary beds, oxygenated blood into capillary beds. That blood then flows to the capillary beds and supplies, oxygen and nutrients to all of the different cells that are being supplied by that vessel. And then those capillaries then lead into small venules, which then lead back into progressively larger veins and then bring that blood eventually back to the heart. So this is how your whole circulatory system works. Those capillaries, though, are leaky. They tend to leak fluid. And that fluid leaks out of the capillaries and accumulates in what are called the interstitial spaces or intercellular spaces, basically the little spaces between adjacent cells. So fluid accumulates in those spaces between the cells. And this is fluid that leaked out of the capillaries themselves. In some cases, it's fluid that actually leaks directly out of the cells, but I think most of the fluid is actually coming out of the capillaries. Well, if you just allowed that fluid to accumulate in the spaces between your cells, your whole body would blow up like a balloon. Your legs would blow up like tree trunks. Your arms would blow up like tree trunks. You'd have all this fluid trapped in these spaces between the cells. You would also dehydrate and starve to death rapidly because all of the fluid would be in the interstitial spaces. It wouldn't be in your arteries and veins where it belongs. And also that interstitial fluid would contain a lot of proteins and other nutrients that your body needs to survive. And if that's not circulating through your body, you would actually starve to death from the accumulation of all this fluid in the spaces between the cells. So the whole function of the lymphatic system is to retrieve this fluid from those interstitial spaces, gather it up, have a series of tiny little lymphatic vessels that eventually flow back and drain back into the bloodstream by draining into the thoracic duct on the left or the right lymphatic duct on the right, where that lymphatic fluid then flows back into the veins to return to the bloodstream. You've probably all heard, I'm sure you've all heard of lymph nodes. Some of you have seen a couple of lymph nodes in dissection. Lymph nodes act kind of like little toll booths along the lymphatic vessels, trapping foreign objects, in particular pathogens and things that might happen to be within the interstitial fluid. And so you have collections of immune cells, B cells, and T cells in these lymph nodes that then combat any kind of infectious things that they might happen to find in that lymphatic fluid. If your lymphatic system starts to have problems, you can end up with disorders like these. The slide on the left shows a condition called lymphedema, which results from the disruption of lymphatic vessels. In the case of this woman, she's had disruption of the lymphatic vessels draining lymphatic fluid from her right upper limb. And you can see what's happened to her right upper limb. It's become very enlarged because of the accumulation of all of this fluid in the interstitial spaces. And if you look very closely at her, you can figure out why this happened. She appears to be missing a right breast, meaning she's had a mastectomy. And unfortunately, one of the common complications of mastectomy is disruption of lymphatic vessels in the axilla. And when that happens, then it leads to the formation of this lymphedema in the limb on the affected side. Even something as simple as a lymph node biopsy during a lumpectomy, just going in and harvesting a lump that might be cancerous, in the process of harvesting some of the lymph nodes, because when you do a lumpectomy, they usually biopsy the lymph nodes to see if any cancer cells may have migrated, metastasized into the neighboring lymph nodes. Just the process of removing those lymph nodes in a lumpectomy can result in this condition of lymphedema. And unfortunately, there's no way to repair these lymphatic vessels. So this is permanent. Typically, what will happen is that the people who've had this happen just have to wrap the affected limb with a tight ace bandage or something to try to squeeze some of that fluid back into the body, or at least prevent more fluid from accumulating. The image on the right side of the slide shows a condition called elephantiasis, sometimes even called elephantitis, but I think elephantiasis is actually a more accurate term for it. This results from a small fly that injects its eggs into the body, and the eggs develop, into little larvae. And the larvae of these little flies like to live in your lymphatic vessels. I guess it's warm and cozy, and there's lots of nutrients for them to eat. So they hang out in your lymphatic vessels, and in the process, they block the lymphatic vessels. And it's most common in the lower limbs. In males, it can also impact the scrotum. I've seen photos of males with a scrotum that looks like a giant basketball. It can affect the upper limb too, though, although it's more common in the lower part of the body. And so it results in this massive accumulation of lymphatic fluid in the limbs, which, people thought looked like elephant legs. And so hence the name elephantiasis. Just a little tangent. Yeah.
I was just wondering if lymphedema is uncurable. Would elephantiasis be? Would there be treatment options?
Elephantiasis is completely curable. Simple antibiotic, kills the worms, the larvae, and you go back to normal. So that's totally treatable. Which is why you don't see elephantiasis in more developed countries that have access to the medicine. It typically tends to be in underdeveloped countries where they simply don't have access to the medication that they need. But it's very easily treatable. I was going to go on a little tangent here about the difference between the words elephantiasis and elephantitis. Anytime you add itis to the end of the word, it means inflammation of something. So meningitis is inflammation of the meninges, the layers surrounding the brain. Arthritis is inflammation of a joint, because arthro means joint. If you were to say elephantitis, it would mean inflammation of your elephants. So I don't think that's really the right word. I think it is more properly called elephantiasis, meaning, sort of resembling an elephant. All right, so that'll be your first dissection. Then we'll move on to a second dissection of the temporal region and an area known as the infratemporal fossa. So the temporal region simply means the area lateral to the temporal bone of the skull. And it's subdivided into two spaces. There's a temporal fossa, which is superior to the zygomatic arch. And it's simply the space that's occupied by the temporalis muscle on the side of your head. Then there's also an infratemporal fossa, which is inferior to the zygomatic arch, but it's also deep to the zygomatic arch and even deep to the ramus of the mandible. And there are a bunch of other structures here, including the two pterygoid muscles, which we've talked about briefly. They're muscles of mastication, but we haven't seen them yet, but you will see them today, because we're going to cut off the zygomatic arch and cut off part of the ramus of the mandible. So be able to see those pterygoid muscles. There are a bunch of branches of V3 in there. Remember, V3 is the mandibular division of the trigeminal nerve. So we're going to see things like the lingual nerve, which is the sensory nerve to the anterior 2/3 of the tongue. We'll see the inferior alveolar nerve, which is the nerve that goes into the mandibular foramen and is sensory to the lower teeth, and eventually changes names to become mental nerve when it comes out the mental foramen in the chin. We might see the buccal nerve, which is a sensory nerve to the mucosa inside the cheeks. We might see the auriculotemporal nerve, which is a sensory nerve to the skin in front of the ear. Those we're much less likely to see, but we'll definitely see lingual nerve and inferior alveolar nerve in there. And then the other thing we'll see in here are going to be the terminal branches of the external carotid artery. And by that, I mean the external carotid artery ends when it splits into a superficial temporal artery and a maxillary artery. And so those are the two terminal branches. So here's an overview of the temporal region, really looking specifically at the temporal fossa. So you have the temporalis muscle sitting within the temporal fossa. Also, the masseter is shown here connecting the zygomatic arch to the mandible, although the masseter is not really part of the temporal fossa. When we cut the zygomatic arch, we're going to try to cut it in such a way that we leave the whole zygomatic arch and part of the zygomatic bone attached to the origin of the masseter. We're going to reflect that piece of bone with the masseter still attached to it, reflected inferiorly. Here's just another view of the temporalis muscle, this time with the whole masseter muscle removed. So the masseter would be originating from the zygomatic bone and the zygomatic arch. And then the masseter inserts all along the ramus and the angle of the jaw. But now by removing the masseter, you can see how the temporalis muscle comes down to insert on the coronoid process in the mandible. So we're going to do a couple of saw cuts that look a little bit like this, not 100% like this, but first thing we're going to do is we're going to take a probe and we're going to jam it under the zygomatic arch as far anteriorly as we possibly can. So you're going to try to jam it under the zygomatic bone just behind the orbit and have the tip of the probe come out in the cheek area. And we'll shove a probe down there and use it as a guide for the bone saw to cut an anterior cut of the zygomatic bone. And then we're going to do the same thing posteriorly. We're going to take a probe and jam it down under the zygomatic arch as far posteriorly as we can, way back near the external acoustic meatus, or as close to it as we can go, and use that as a guide for the bone saw and cut the zygomatic arch posteriorly. So we'll remove the zygomatic arch. And as I said, we're going to leave the zygomatic arch actually attached to the masseter muscle and simply take that bone and the muscle and reflect it inferiorly. So the masseter is going to reflect inferiorly. We'll leave it attached to its insertion down here near the angle of the mandible. Then we're going to make a couple of cuts in the ramus of the mandible, not exactly like these cuts, though. I'll describe them for you when we get into lab. We're going to cut off the coronoid process to detach the temporalis muscle, and we'll try to reflect some of that temporalis muscle superiorly. We'll make another cut back here across the neck of the mandible. So in this netter painting, they didn't cut all the way across the neck, but we're going to cut completely across the neck of the mandible back here. And then we'll make a third cut down here across the ramus, not quite as low as netter cut here. We'll make a horizontal cut across the ramus. So we'll be removing the whole upper part of the ramus of the mandible. And that's going to then allow us to look into this area called the infratemporal fossa. So when we do that, we're going to see two muscles. There's a lateral pterygoid muscle, which sits more superiorly. It has its origin. If you read the book, the origin's a little bit more complicated than this, but I would be thrilled if you could just tell me that its origin is on the lateral pterygoid plate. The pterygoid plates are two extensions of the sphenoid bone that extend down from the sphenoid bone in the base of the skull. Lateral pterygoid origin is a little more complicated than that, but it's primarily from the lateral pterygoid plate. And then it has its insertion over here on the neck of the mandible, but it's also inserting onto the joint capsule that surrounds the temporomandibular joint. That's the joint between the temporal bone and the head of the mandible. Your TMJ, some people have heard of that because some people have a condition called TMJ disorder. So the temporomandibular joint is a synovial joint, like most joints in the body. So it has synovial cartilage, it has a synovial membrane, and it's surrounded by a fibrous joint capsule. So this lateral pterygoid muscle is having part of its insertion directly onto that joint capsule of the TMJ. There's also a medial pterygoid muscle, which again, the origin is a bit more complicated than what I'm going to say, but it's primarily originating from the medial pterygoid plate. Again, an extension that extends down from the sphenoid bone. And then it has its insertion on the inner surface of the ramus, especially down near the angle of the mandible. They can be tough to distinguish at first because this area is not nearly as clean and pretty as Netter shows it here. There's fat and connective tissue and stuff in here. But you can usually distinguish the muscles based on their fiber direction, with the lateral pterygoid fibers going pretty much horizontally and the medial pterygoid fibers angled down at a much more sharp angle. I haven't mentioned the innervation of these, but what nerve innervates both of these muscles? Trigeminal, which part? V3. Yeah, these are muscles of mastication innervated by V3. Here's a different view of them. We will not see this view, but it's a nice view to be able to appreciate their attachments. So you can just barely make out the pterygoid plates in here. They're not that visible. The medial pterygoid plate is just barely kind of visible right here, extending down from the sphenoid bone. Lateral pterygoid plate is mostly hidden back there, but you can see the fiber directions, and you can see the insertions pretty clearly. So lateral pterygoid extending from lateral pterygoid plate to insert on the neck of the mandible and the joint capsule surrounding the TMJ. Medial pterygoid extending from medial pterygoid plate down to insert on the inner surface of the mandible, down near the angle of the mandible. This also begins to show some of the other structures that we'll be looking for in the infratemporal fossa. So you can actually see V3 up here exiting the foramen ovale and then beginning to split into a number of separate branches within the infratemporal fossa. And then we can see the maxillary artery, which is one of the terminal branches of external carotid. So here's our overview of V3, which we'll be looking for in the infratemporal fossa. So V3 exits the foramen ovale and then enters into this infratemporal fossa that we're going to be dissecting, and then gives off a bunch of branches, two of which we should have a pretty good chance of seeing, the others maybe not. There are a lot of little branches that come off of V3 that go directly to the different muscles of mastication. So there's a temporalis branch, a masseteric branch, obviously to temporalis and masseter muscles. There are pterygoid branches to the two pterygoid muscles. We won't really see those branches to the muscles of mastication. There's a nerve called the buccal nerve, which is it's entirely a sensory nerve to the mucosa on the inside of the cheek. Don't confuse this with the buccal branch of the facial nerve. Facial nerve 7 is the one that innervates all the muscles of facial expression and has a temporal, zygomatic, buccal, mandibular, and cervical branch. That's a completely different cranial nerve. Buccal just means cheek, so both nerves got the same name, even though they're derived from different cranial nerves. That buccal nerve, I've seen it a couple times, but it's not one that we usually find. The two that we'll normally see would be lingual and inferior alveolar. So lingual is going to sit a little bit more anteriorly. So if you see two big nerve branches in here, the one in front is almost always lingual nerve. And that's going to be entering into the tongue, where it's going to provide general sensation only to the anterior 2/3 of the tongue, not taste, just general sensory touch, temperature, and pain to the anterior 2/3 of the tongue. There is a branch that's mentioned on here. There's a nerve called the chorda tympani, which is actually coming from the facial nerve. That chorda tympani joins the lingual nerve and travels into the tongue. It's the chorda tympani coming from cranial nerve 7 that's responsible for the sense of taste to the anterior 2/3 of the tongue. But that's really a hitchhiker. It's part of the facial nerve that's hitchhiking along V3 to get into the anterior 2/3 of the tongue. The other nerve that we'll definitely see is inferior alveolar nerve. Depending on exactly where we make that cut, that saw cut through the ramus of the mandible, if you're lucky, you may actually be able to see this inferior alveolar nerve going into the mandibular foramen on the medial aspect of the ramus of the mandible. So then that inferior alveolar nerve then disappears into the mandible, travels through the lower jaw, sensory to the lower teeth, and then what's left of it eventually exits the mental foramen to become the mental nerve, which is sensory to the chin and the lower lip. A couple other nerves in here that we may or may not see. Right before the inferior alveolar nerve enters the mandibular foramen, it gives off a very tiny little branch called the mylohyoid nerve. That mylohyoid nerve is not going to enter the mandibular foramen. So most of inferior alveolar nerve goes into the mandibular foramen, but mylohyoid nerve does not. It actually runs in a shallow little groove along the inner surface of the mandible, comes down here under the chin, and it's the mylohyoid nerve that's actually innervating the mylohyoid muscle, as well as the anterior belly of the digastric. These are two other muscles of mastication. So V3 eventually innervates temporalis, masseter, medial pterygoid, lateral pterygoid, and then by way of this mylohyoid nerve is also innervating mylohyoid muscle and anterior belly of digastric. The last branch that we also probably will not see, but just be aware of it, there's a branch of V3 that then turns superiorly, goes right up in front of the external acoustic meatus. It's called the auriculotemporal nerve. This is a sensory nerve to the side of the head, basically the skin anterior to the ear. So remember that V3 is both sensory and motor. It's sensory to the whole lower side, the lower face, but also extends up on the side of the head in front of the ear. And then it's motor to those muscles of mastication. So in the infratemporal fossa, we're also going to be looking at a couple of arteries. So there's our common carotid artery way down at the very bottom of the slide, not labeled. It's going to split into internal and external. So internal carotid is going to be more posterior, and that's going to pass through the carotid canal into the skull to the circle of Willis. The external carotid sits more anteriorly, and that's what gives off all of the branches to the face. So there's superior thyroid artery right there, superior laryngeal going into the larynx, occipital artery back here that we didn't really look for, lingual artery and facial artery going forward into the face. And then if you keep following external carotid up, sitting right behind the ramus of the mandible, it finally terminates when it splits into these last two branches. One of these is called the superficial temporal artery, which is going to supply blood to the outside of the head, basically, the area of the temporalis muscle. And the other terminal branch is called the maxillary artery, which passes anteriorly through the infratemporal fossa. So we'll be looking for maxillary artery in the infratemporal fossa. The maxillary artery gives off several branches in the infratemporal fossa. There are only two that we're interested in this class. And even these two, you may have trouble finding, but you can look for them. One of them is the inferior alveolar artery. So remember that the inferior alveolar nerve is a branch of V3 that enters into the mandible through the mandibular foramen, right in this area of the ramus. As the inferior alveolar nerve enters the mandibular foramen, it's joined by an inferior alveolar artery that also goes into the foramen. That inferior alveolar artery is supplying blood to the bone of the mandible because, bone is living tissue. It needs a blood supply. Inferior alveolar artery also supplies blood to the lower teeth because the teeth are also living tissue. And in addition to having a nerve supply, they also have a blood supply. So there are tiny little blood vessels that extend from this artery up into the lower teeth. And there is, we couldn't see this in lab, but there is even a tiny mental artery that comes out the mental foramen, which would be the continuation of this inferior alveolar artery. So it's, you can, you can identify that inferior alveolar artery by actually seeing it join the nerve and entering into that foramen. So that's one branch off of the maxillary that we're going to look for. The other one is even harder to find. That's the middle meningeal artery. This is the artery that is passing through the foramen spinosum into the skull and forms those grooves on the inside of the skull. And you can actually see this artery within the dura mater surrounding the brain. This is where it's coming from. So it branches off of the maxillary artery in the infratemporal fossa, goes up through the foramen spinosum into the skull, and then travels through the dura. This is the artery that can be lacerated if you have a fracture to the pterion, that real thin area on the side of the skull. Yet another view of infratemporal fossa. We won't have this view either, but it's a nice view to help understand the relationships between these different structures. So there's V3 coming through foramen ovale, giving off a bunch of little branches that aren't really identified here. The main two branches include lingual nerve, which is going forward into the tongue, and then inferior alveolar nerve, which is coming down to pass through the mandibular foramen into the mandible, along with the inferior alveolar artery running side by side. But just before the inferior alveolar nerve and artery enter the mandibular foramen, they both give off very tiny little branches called the mylohyoid nerve and mylohyoid artery that are going to run along the medial surface of the mandible down under the chin down here to supply the mylohyoid and anterior belly epigastric. Then you can see the maxillary artery here, so that would be branching off the external carotid just behind the mandible, and it's going to pass forward through the infratemporal fossa. The maxillary artery actually continues into the maxilla. It goes into the bone, but we can't follow it into the bone, so we lose sight of it at this point. But it actually gives off a number of other branches inside the face, including blood supply to the upper teeth, but we won't see any of that. We'll just see the maxillary artery kind of passing through the infratemporal fossa. Hopefully we'll see it giving off that inferior alveolar artery going into the foramen, and maybe see it giving off middle meningeal artery, which is passing through the foramen spinosum up here. Remember, foramen spinosum sits right behind foramen ovale in the skull, so it's not surprising to see that artery sitting right behind V3, as foramen spinosum is right behind foramen ovale. Oh, by the way, I forgot this was on here, but you can see those pterygoid plates a little more clearly in this particular view. Again, we're looking at this in a kind of a sagittal cut section, which we won't actually get to see. Last thing I want to talk about just briefly, we're not really going to dissect this, but it's an interesting thing to know about clinically, is the temporomandibular joint. This is one of those things kind of like carpal tunnel when people say, do you have TMJ? Why, yes, I have two of them. Because TMJ just means temporomandibular joint. You know, when people ask if you have TMJ, they mean, do you have TMJ disorder? Kind of like, do you have carpal tunnel? Yes, I have two of them. But you have carpal tunnel syndrome, maybe, maybe not. So the temporomandibular joint is the joint that's formed between the temporal bone. There's actually a little fossa, a little indentation on the temporal bone called the mandibular fossa, which is receiving the head of the mandible to form this joint. And you can see the joint capsule here, this fibrous joint capsule that completely surrounds the joint and helps hold the head of the mandible within the mandibular fossa of the temporal bone. There are a couple little ligaments here. You don't have to worry too much about these. You might see the sphenomandibular ligament because it does sit in the infratemporal fossa. We won't see the stylomandibular ligament, but these are just a couple of additional ligaments that help hold the mandible onto your head so it doesn't just fall off. If you look very closely at this cut section into the temporomandibular joint, it's actually a little more complicated than most synovial joints. Most synovial joints, you have just two bony surfaces lined with hyaline cartilage that are in direct contact with one another. Then you've got your synovial membrane surrounding that secretes a thin layer of synovial fluid, and you've got your fibrous capsule around that. The TMJ has that, but it has something additional. It has a cartilage disc that actually sits in the middle of the joint. So the head of the mandible is actually not in direct contact with that mandibular fossa of the temporal bone. The cartilage disc actually separates them. When the jaw is in the fully closed position, that articular disc sits up in that little pocket on the temporal bone, up in that mandibular fossa. And then the head of the mandible sits nicely within a little indentation or a little pocket on the disc. But when the mandible is in the fully open position, something unusual happens. That whole disc actually slides forward out of that nice little pocket in the mandibular fossa. The head of the mandible actually ends up sliding forward onto this little bump in front of the mandibular fossa. I forgot to mention it, but it's labeled over here. It's called the articular tubercle. So that the head of the mandible slides forward when you fully open the jaw. So it's kind of perched on that little articular tubercle right there. It's at that point when the jaw is fully open that it's actually susceptible to being dislocated. If you happen to have your mouth wide open and you get hit in the side of the jaw, it's relatively easy for the head of the mandible to then pop out of the mandibular fossa. And when it does that, it ends up stuck here. It ends up popping anterior to that articular tubercle, and the head of the mandible ends up getting stuck in the infratemporal fossa. And when that happens, you can't close your jaw. So you know it if you had a dislocated temporomandibular joint, because you'd be walking around like this. And you can't close your mouth. I've heard stories from people who've had this happen. I had a student years ago who raised Great Danes, dogs that are the size of a small horse. And I guess she was rolling around on the floor, wrestling with one of them, just having fun. She's kind of laughing, got her mouth open. One of these giant heads, like a massive bowling ball, comes up, hits her in the side of the jaw. And she's stuck like that. And she, I guess she had no fear. She just grabbed her jaw and just yanked it down and popped it back in. They don't normally recommend that. Although I think the doctor ends up doing the same thing. They might give you a little anesthesia, but they're just going to end up doing pretty much the same thing. They just yank it and put it back in place. Now you've all probably heard of TMJ disorder. You hear about people who have clicking jaws. It clicks every time they open and close. They might grind their teeth at night. They may have pain in the temporomandibular joint. And I mean, that can happen from something extreme like a jaw dislocation. When you dislocate the jaw, it disrupts the ligaments and it damages the disc. And that can lead to TMJ disorder. But more commonly, it's just a thing that develops gradually over time. If your teeth don't occlude right, like if you need braces and your teeth aren't lined up properly, just every time you close your jaw, it can cause the mandible to twist slightly because the teeth aren't lined up right. That can put stress on the TMJ. People who grind their teeth overnight, bruxism, I think is the word for that. Just because of that strain they're constantly putting on the joint because of constantly grinding their teeth. They can end up with TMJ disorders over time. And unfortunately, it's kind of hard to treat. And I'm not sure if this is still true or not, but I remember years and years ago looking into it and found that it was hard to get insurance to cover any of the treatment too. If I remember correctly, the medical insurance would say, oh, it's really a dental problem. So if you have dental insurance, they'll cover it. And then you go talk to the dental insurance people and they say, oh no, that's got nothing to do with your teeth. It's actually a medical problem. Your medical insurance would cover it. So nobody wanted to cover it basically. I don't know what the current status of that is these days. I don't know if they finally fought it out and decided who's going to cover it or if nobody covers it. But I mean, there's not a whole lot you can do for it anyway. Once that disc starts to erode down, it's not like you can replace it. I think the main thing they do for some forms of temporomandibular joint disorder is sometimes what happens is the capsule becomes loose, so that disc slides forward and backward more than it should. So they can go in and surgically to sort of tighten up the capsule to minimize the movement. The other thing is just to treat whatever the source of the problem is. So if you do grind your teeth at night, you know, there's all kinds of mouth guards and things that they can give you to minimize the tooth grinding. But other than that, I'm not sure what they can actually do for it. Yeah.
Will that be only mandible goes up and down, or like that also involves like it slides to the front?
So your mandible does actually slide forward and backward a little bit just during normal chewing motion. The masseter in particular helps move the jaw forward. The temporalis pulls it back. The pterygoids also move the mandible side to side a little bit during chewing motions. So some of that kind of motion of the head is actually normal just during normal chewing and even normal talking.
If there's a crack every time that happens.
Yeah, you get the cracking noise. Yeah.
Yeah.
So that's probably because of too much movement of the disc in the space, or it could even indicate that the disc is starting to wear down a little bit and you're getting a little more bone on bone contact. All right, that's actually everything I have for you today. So any other questions? If we got no other questions, I'll let you go early and see you in lab in a little bit.